Welcome to This Explainer. Today, we're going to break down the sheer, overwhelming panic that usually hits the room when a patient goes into ventricular tachycardia. We're going to replace that panic with a clear, actionable, and honestly, mathematically brilliant clinical framework. If you've ever felt your own heart rate spike the second a patient's monitors starts alarming with VT, well, you're in the right place. Okay, let's just glance at our agenda for today. We'll start with the 10,000-foot view, then move into managing the sick heart, surviving the electrical storm, looking at the innocent bystander heart, and finally, a really counterintuitive strategy, speeding up to slow down. This maps perfectly to the two distinct pathophysiologic buckets of VT and exactly how we need to treat them. All right, let's jump right into section 1, the 10,000-foot view. We really have to start with a massive paradigm shift to lower our own cognitive load. As the medical experts in our source material put it so perfectly, the minute you see that on the monitor, you start getting kind of tachycardic, and it's easy to stop thinking. VT is absolutely terrifying, right? But your heart rate shouldn't spike just because the patient's does. And that is exactly why we need a rock-solid mental model to rely on when the pressure is on. So here is our golden rule. This is literally the foundation of everything we're talking about today. You have to divide VT into two categories. Category 1 is the sick heart. This means structural disease, and it typically presents as monomorphic VT. Category 2 is the innocent bystander heart. This is an electrical or trigger problem, usually presenting as polymorphic VT. The absolute crucial takeaway here is that the treatment for one can actually harm the other, so you've got to know which bucket you're working in. Moving right along to section 2. Managing the sick heart. Let's tackle that first bucket, where the physical heart itself is the culprit, usually due to structural damage from something like a prior heart attack. You need to understand exactly why these patients might look totally fine for a second and then just rapidly crash. It's because the rhythm creates a literal synergy of badness. You get severely reduced stroke volume, loss of that vital atrial kick, which totally tanks your preload, highly inefficient ventricular contraction, and skyrocketing oxygen demand in the heart. This completely destroys perfusion. Basically, if a patient with structural heart disease presents with wide complex tachycardia, assume it's VT and act fast. Do not waste time analyzing complex EKG algorithms when the patient is actively decompensating right in front of you.
So what's the play? Well, you shock them. But there is a massive catch. As the intensivists point out in our sources, you break it, you buy it. What does that actually mean in this context? It means you absolutely must fully sedate these awake patients before shocking them. If you just shock a terrified, wide-awake patient, you trigger a massive endogenous catecholamine surge. It is literally like dumping kerosene on an arrhythmia fire. But of course, when you push heavy sedation, their blood pressure is going to tank. You break the blood pressure, you buy it.
So here is the exact order of operations to safely cardiovert without causing further adrenergic harm to your patient. Step 1. Start your vasopressors early. Have them hanging and running before you push the sedative. Step 2. Push adequate sedation. Precedex is great here because it actually has a helpful side effect of bradycardia, but propofol works too. Step 3. Deliver a synchronized shock, starting right at 200 joules. Prepare the pathway, push the sedation, then deliver the electricity. Now, while we're setting up for that shock, we also want to get antiarrhythmics on board in parallel to help make sure that shock actually sticks. Our first-line agent is amiodarone, pushed at 150 milligrams over 10 minutes, followed by a drip. If for some reason that fails, our second-line agent is lidocaine. Now, I know some of you might be wondering, hey, what about procainamide? Didn't the ProCameo trials say it was better? Well, amiodarone remains our preferred first-line agent for a very specific, kind of wild statistical reason. That ProCameo trial, it had a fragility index of exactly one patient, meaning if the outcome of just a single patient had been different, the statistical significance favoring procainamide would have completely vanished. Plus, they only monitored adverse events for 20 minutes, so amio still holds the crown for the structurally sick heart. All right, let's jump to section 3, surviving the electrical storm. What happens when this sick heart gets stuck in a relentless loop of recurrent shocks and continuous VT? The real nightmare here is that you get them out of VT, but you just can't keep them out. It's a self-perpetuating adrenergic disaster. To break an electrical storm, you have to meticulously hunt down and reverse the underlying physiologic stressors driving it. We're looking for new ischemia, so get a 12 lead the second they convert because they might need the cath lab right now. We're aggressively treating hypoxemia or fevers. We're checking the ACID device, which might literally be malfunctioning and continuously shocking them, which of course drives their panic up. And importantly, we're hunting for electrolyte depletion.
When it comes to those electrolytes, the crucial thing to remember is that we do not just settle for normal ranges. You need to target aggressive numbers to stop this storm. We're aiming for a potassium of 4.4 and a magnesium of 2.2. There's really robust evidence behind this. Seriously, do not underestimate how a dropping magnesium level from something as simple as a routine bowel prep can throw a structurally sick heart right back into a vicious storm.
Because the patient's sheer panic and that massive catecholamine surge literally drives the continuous arrhythmia, robust sympatholysis is absolutely critical here. You have to cool the system down. Our strategies include deep sedation or even full intubation to induce general anesthesia-style calm. We use Precedex, fentanyl pushes for pain, and short-acting beta blockers like esmolol. Now, I know giving a beta blocker to a patient in cardiogenic shock sounds absolutely terrifying, but remember, esmolol has an 8-minute half-life. If it turns out to be a terrible decision, you turn it off and it washes out incredibly fast, which gives you a lot of peace of mind when managing such a fragile patient. If medications fail, we can escalate to mechanical support like an Impella or VA ECMO to physically offload the heart. But we can also use this incredibly fascinating physical block called stellate ganglion block. It basically acts as an autonomic circuit breaker. By injecting a local anesthetic directly into the sympathetic nerves in the neck, you're quite literally severing the sympathetic drive that's terrorizing the heart. It's a real game changer.
Okay, moving to section 4, the innocent bystander heart.
Let's shift gears completely to our second bucket, where the core problem is entirely different. The big question we have to ask here is, what if the heart is actually structurally healthy? If the patient has no history of heart failure or a prior MI, we are most likely dealing with polymorphic VT, or torsades de Pointes. In this scenario, the heart is simply an innocent bystander. It's just reacting to a toxic external environment. It's a mathematical setup for disaster. You've got a prolonged QTC interval combined with a slow heart rate. Add in some polypharmacy, maybe some Zofran or azithromycin, and a little renal dysfunction so they can't effectively clear the drugs. And boom, you've created the absolute perfect storm for an R-on-T phenomenon. Which brings us to our final section, speeding up to slow down. This is the final, and honestly most fascinating concept we're covering. The answer for how we treat this completely flips the script on everything we just talked about. You have to speed up the heart to fix the rhythm. Yes, I know, it sounds totally counterintuitive to give beta agonists to a patient with a tachyarrhythmia, but it is mathematically brilliant. Also, quick aside here, please do not use amiodarone in this specific scenario. It prolongs the QTC and will make everything so much worse. So aside from aggressively pushing magnesium, we intentionally drive the resting heart rate up to around 100 beats per minute. By doing this, we drastically stack the probability odds in our favor. We can do this with pharmacologic modalities like isoproterenol, dobutamine if they're hypertensive, or even epinephrine or dopamine if they're hypotensive. Or we can use a literal approach, overdrive pacing. Just insert a transvenous pacemaker and simply pace them right at 100 beats per minute. Let's actually look at the math behind this intervention. At baseline, the patient has a long QTC, a slow heart rate, and a super high risk for an R-on-T event. As our intervention, we administer a drug like isoproterenol or start overdrive pacing. Well, because the formula used to calculate the QTC inherently relies on the RR interval, making the heartbeat faster physically shortens that RR interval. The result? You literally shorten the vulnerable repolarization window. This drastically reduces the VT risk while you just wait for those offending medications to naturally wash out of their system. It's brilliant. And that brings us to our final thought today. The next time that monitor alarms with a wide complex tachycardia, will you fall victim to the panic? Or will you calmly step back and determine which bucket your patient actually falls into? Understanding these two completely different mechanisms ensures that when the time comes, you'll be armed with the exact right strategy to save a life. Thanks for joining me on this explainer, and as always, keep learning.